MDR and XDR-TB are threats that will take advantage of every opportunity to spread and amplify. As we know now, these opportunities come from system-wide weaknesses and gaps in the provision of healthcare. Sound basic TB control is the best way to prevent drug-resistant TB. Fundamental weaknesses and gaps in health systems impede sound TB control. Substandard treatment of normal TB drives the development of multidrug resistant strains. In turn, substandard treatment of MDR-TB drives the development of XDR-TB. Equally of concern, drug-resistant TB creates enormous additional demands and pressures on components of the health systems that are already weak. In other words, drug-resistant TB severely affects how we respond to other health crises, to other health challenges. Drug-resistant TB stress the capacity we need at a time of great demand from HIV/AIDS, malaria, and others. Ladies and gentlemen, let us look at what that means. Diagnosis of MDR-TB is challenging and depends on high-quality, well-staffed, and well-equipped laboratories, ideally operating at biosafety level 3. Laboratories are arguably the most neglected component of health systems. The capacity is simply not there in most high-burden countries. New diagnostic tools has become available, but technology transfer is very slow, and too many laboratories are not equipped nor staffed to absorb these additional demands and technical advances. Fixed-dose combinations were developed specifically to reduce the risk of drug resistance. Logically, they are easier to store and distribute. Prices are as the same, and actually in some instances they are lower. But loose pills and treatment is easier to finance than the loose pills. And yet, these combination drugs, these drugs are still underutilized in nearly all high-burden countries. Mr. Bill Gates, this morning we were talking about it. Instead of taking 2 to 4 pills, one has to take 13 pills. Put yourself in the position of the patients. 13 pills, not 13 candies. That makes a difference. If health authorities were fully aware of the consequences of poor patient compliance, do you think utilization would increase? Sure. The current recommended second-line treatment regimens are also complex, of long duration, and require intensive monitoring of adverse effects and treatment outcomes. Stringent efforts are needed to ensure treatment adherence. We already face a critical shortage of healthcare personnel. Where do we get the additional staff to do this kind of work? Compare with normal TB. I find the term interesting, normal TB. TB is not normal. Compare with regular TB, shall I say, the cost of treating MDR-TB can be as much as 100 to 200 times higher. And this is when the country benefits from the concessional price offered by the Green Light Committee initiative, and I would like to thank you for that. If drugs are procured on the open market, ladies and gentlemen, the price increase can soar 1,000-fold. Either way, patients and their families face catastrophic expenditures. Ways need to be found to make care available at no cost. We know this brings the best results, especially in resource-poor settings. Patients, communities, and civil society need to be fully engaged in prevention, treatment, and care. Procurement systems must be able to ensure an uninterrupted supply of drugs. Systems of regulatory control, and I'm happy to see Minister Shao is here. He's the head of the SFDA in China. We need your help. Systems for regulatory control must ensure that these drugs meet acceptable quality standards, are sold on prescription only, and are prescribed only by accredited practitioners. Infection control. Infection control for airborne pathogens must improve in hospitals and other congregate settings, especially when HIV/AIDS is widespread. Better collaboration. Better collaboration is needed with HIV programs. People living with HIV has a higher risk of MDR-TB, with a greater increased mortality and greatly reduced survival time. All of these constraints are also an inventory of the most common and most crippling weaknesses or gaps in health systems. Currently, less than 5% of the estimated MDR-TB cases are being detected by national TB programs, and fewer than 3% are being treated according to WHO recommended standards. The costs, as I said, are catastrophic. In all 27 high-burden countries, the cost of treating a single patient vastly exceeds average annual per capita income. Poor case detection means poor data, and this means poor drug forecasting and weak incentives for manufacturers who tend to produce on demand. Supplies of second-line drugs are inadequate to manage even the small proportion of cases enrolled for treatment. Most, if not all, second-line drugs are sold in the private retail market, often over the counter. Where is the monitoring of adverse effects? And where is the assurance of treatment compliance and adherence? Obviously, ladies and gentlemen, this is a situation set to spiral out of control. Call it what you may, a time bomb or a powder keg. Any way you look at it, this is a potentially explosive situation. The conclusion is equally obvious. We need dramatic improvements through innovation in case detection and standardized management with quality assured drugs across the health system. This means in the public, private, and voluntary sectors, in HIV programs and in hospitals, as well as in national TB programs. The best way to do so is through a policy that drives for universal, equitable, and affordable health coverage and strengthens all capacities needed to reach this objective. I urge you to make the right policy decisions with appropriate urgency. At a time of economic downturn, the world simply cannot afford, we simply cannot afford to let a threat of this magnitude, complexity, and cost spiral out of control. It is in this climate that I urge you, ladies and gentlemen, policymakers, the decision is in your hands. Rest assured of the full support from WHO and its Stop TB partnerships. Thank you.